let you guys make your own decisions. Okay, so the background. As you know, if you are awake and living in the US in 2023, the issue of what's the appropriate way to deal with gender confused children has become highly politicized. And we know that in Texas and Florida, they have criminalized access to what is called gender affirming care by minors. In California, Senate Bill 107 has made California a sanctuary state for minors to get the so-called gender affirming care without parental consent. And we see that Democrats and Republicans are on opposite sides of this issue. And what I think is unfortunate is that this is a moral issue that shouldn't be decided based on your political affiliation. Because as with many issues, if one party does A, the other party does not A, right? Because they want to distinguish themselves. And maybe one party gets it right, but I'm not sure that the reason why they get it right is because of the right moral and non-moral facts. So I think it's important to disentangle the ideology and the ideological wars from what is actually going on factually and morally. Right? And then maybe come back to it, right? From a political perspective, but I think it's more important to understand the moral issue and understand the facts first. Okay, so what's the moral dilemma? What's the moral tension here? Well, the proponents of gender affirming care, they say that when you have a gender confused child, someone who is has a particular sex, right, which is a biological feature, a mutable feature, and they say, my identity is other than my biological sex, that these children can consent to treatment, right? They can exercise their autonomy, and that this gender affirming care promotes their well-being, right? It maximizes good consequences for them and is what any good, tolerant, accepting parent should do, right? This is Charles and the Virtue of Acceptingness. Now, the people who are on the opposite side, who are critics of gender affirming care and they want an alternative, they say that kids cannot meaningfully consent to treatment, that gender affirming care involves irreversible mutilation and sterilization of children, thus failing to maximize good consequences for kids and also foreclosing future possibilities, violating the right to an open future. And it's also simply not good parenting. So it's a failure to uphold the virtue of parental integrity. Okay, so first, before we explore the moral considerations, the facts, because the facts are multi-layer and they're complex. Why are children seeking gender affirming care? Do gender confused children grow up to be transgender adults? Are gender confused children capable of making medical decisions of this magnitude? What is gender affirming care? Are there any alternatives? Does gender affirming care work? And then, do the alternatives work? And then the moral considerations. What are the rights that children have? What rights do parents have? Is gender affirming care in harmony with parental integrity? What do parents and children deserve in the context of pediatric medicine? How should parents deal with gender confused children? Should the government override parental decision making? Okay, so first, let's start with the factual considerations. The first important fact is that there has been a significant rise in demand for gender care services. So gender dysphoria, you probably know, is this rare psychological condition where the individual, often male, and from a very young age, feels a deep and persistent distress about their sexed body, right? And the word biological before sex is redundant because there's only one kind of sex. However, people often refer to biological sex to make it clear that we're talking about the material reality of what kind of gametes you produce. Do you produce sperm or do you produce eggs? So we have seen a rapid rise in transgender identification among high school students. Various surveys show like between 2 and 9%, depending on the survey, depending on the part of the country, of students have begun to identify as transgender. In the UK, where this phenomenon appear earlier than in the US, they had a gender clinic called the Tavistock Clinic, and they saw a 53-fold increase in gender treatment referrals in one decade, between 2009 and 2019. We also see that there has been a change in who gets a referral. As I mentioned earlier in the first bullet, the traditional presentation of gender dysphoria was males, very young males, expressing distress about their sex body. But what we have seen in the last decade and a half, is that now it's girls who are showing up in these gender clinics with a self-diagnosis of gender dysphoria. So, for example, in the UK, there has been a 4,400% rise over the previous decade in teenage girls seeking gender treatment. So now it's teenage girls, not young boys, who are sort of the face of gender dysphoria. And 70% of all gender surgeries are performed on females. Now, this it's interesting because generally conditions don't change, the demographic that they affect in this sudden and radical way. So, what could be the source of the change in disease presentation? Some researchers, psychologists, have claimed that there is a certain novelty to non-binary and trans identities. Is something that is new, and teenagers are attracted to novelty. And what supports their assertion is that they say, look, we have seen the earlier traditional form of disease presentation, which was very rare, was these very young boys with gender dysphoria. It happened early in childhood. And now we see the onset in adolescence, which is something that we had never seen before. So the fact that it's happening on adolescence has led researchers to think about, well, what is the psychological makeup of an adolescent? And adolescence is a time of exploration, but it's also a time when people are looking for a sense of belonging. So Lisa Littman, she's a researcher, and she did a study a few years ago where she tested the hypothesis that there's a possibility that the reason why we're seeing such a rapid increase among teenage girls presenting with gender dysphoria is peer contagion, right? So much like fads among teenagers, they're spread when you have, one kid with a particular condition, maybe that is leading other kids in that same friends group to also develop, right, or acquire a similar condition. And we have seen this happening with previous phenomena in teenage mental health, like cutting or anorexia or eating disorders. And girls seem to be quite prone to this contagion. So she coined this term ROGD, rapid onset gender dysphoria. And what she noted is that the girls who were showing up with gender dysphoria in adolescence, it appeared in clusters, right? So where there was already a girl with gender dysphoria, then, a couple of weeks or months later, all the girls or the majority of the girls in that social group also claim to have gender dysphoria or trans identity. So What she says is that rapid onset gender dysphoria happens in adolescence, so it's this late onset, and generally what parents notice with these adolescent girls is that their gender dysphoria and their trans identity came after a period of immersion in social media, right? Something that increased radically in the lockdowns of 2020. And like I said, a clustering around friends groups. Now, this phenomenon of psychological conditioning spreading among girls, teenage girls, and tying it to social media is something that we saw a couple of years ago, where girls were, quote unquote, catching Tourette's on TikTok. So there were Tourette's influencers, and then girls were spending a lot of time on Tourette's, and then they were developing Tourette's. And it's not like they were faking it. The people who looked at these girls, they knew that they didn't have Tourette's, but it was such an intense process of self-suggestion that it was very difficult for them to for these girls to stop. So what researchers are claiming is like, look, if kids who are exposed to Tourette's influencers can develop these tics, involuntary speech, then social media could also be spreading contagion when it comes to gender identity, right? So these girls, as I said, they have been watching a lot of Tourette influencer videos. And what they got from themselves joining this community of Tourette influencers was a sense of belonging, which is something that every teenager craves. So the next step is, well, we have a whole host of gender identity influencers who are promoting transgender or non-binary identity. Could the same thing be happening, right? Okay, so as I said, these researchers also take into consideration, what it means to be a teenager. How is your brain developing and what's happening psychologically during the teenage years? We all know that every era has its own unique cluster of teenage fads, whether it's, to be goth or grunge or, you name it. So adolescence is a time of identity self-exploration. And the interesting thing when it comes to gender dysphoria, it's not something that you can test, and it's not something that has a set diagnostic criteria, right? So we're kind of like feeling our way around trying to figure out who has gender dysphoria and who doesn't. Now, the other important fact, other than, the psychological makeup of teenage girls, right, is that the majority of children who are diagnosed as having gender identity disorder do not grow up to be transgender adults. This is a transient thing. It's something much like these kids are not going to grow up to be goth adults. Most of the kids with gender identity disorder grow up to be perfectly happy with their sex bodies. Studies showing this vary. This is like a low estimate. 67% found a natural resolution for their gender dysphoria post-puberty. Some studies have shown over 80% of kids who have gender confusion once they go through puberty, which is quite traumatic, especially for girls, because of the radical change in your body. Eventually, they get used to their body. They don't feel dysphoric anymore. And for those who have a subclinical diagnosis, meaning they have dysphoria, but not quite there where we feel confident diagnosing them, almost 100% of them, right, grew up to not have gender dysphoria. And the other important fact here is that most of these kids who have strong cross-sex identification, meaning females who identify with males and males who identify with females, right? They grow up to be homosexuals. So most of these kids who eventually get over their gender dysphoria end up to be gay. Okay, So the next important fact is, which piggybacks on what we just mentioned, that most kids grow up to no longer have gender dysphoria. They don't grow up to be transgender adults, is that most kids desist, and those who don't sometimes detransition. So detransition is a growing phenomenon, and you have a video from 60 Minutes, an excerpt of a video that interviews several detransitioners. But it's something that we have started to see more and more over the last 3 years, and it's likely undercounted because the people who are undergoing gender treatment, right, they are being counted as long as they're part of a gender clinic. But once they stop going to a gender clinic, there's no way of record keeping, right? So the estimates that people get about how prevalent detransition is from online groups like Reddit groups or Discord groups with the label detransitioners or detransitioner support. But we do know that the detransition rate after an average of 5 years in gender-affirming care is at least 30%. So 1 in 3 kids, adolescents who have been for at least 5 years under gender-affirming care will say, no more, I'm going back to my sex. And the typical age of detransitioners are older teens to young adults. We see detransitioners in their early and mid-20s. The most famous detransitioner is a California girl known as Chloe Cole, and that's her. She has spoken against that California bill that made California a sanctuary for gender-affirming care without parental consent. And she's currently suing her doctors because of the care that she got, that she says she was too young to consent. And like I said earlier, many of these detransitioners are homosexual, gay, or lesbian. So this is what she says, Chloe Cole. She said, we will shut down these barbaric practices. She had a double mastectomy at 15 and is suing her doctors. And the most common surgery that kids are getting, because again, remember that most of the surgeries are done on girls, is the first surgery is the double mastectomy, the removal of the breast. Okay, further factual considerations. So what is the typical patient that comes to a gender clinic seeking hormones or puberty blockers? Well, gender confused kids tend to have an elevated risk of suicide compared to the general population, and it's something that you have probably heard about, right? The suicidality. But we also know that most of these kids don't just have gender dysphoria. They have also a whole host of other mental health conditions. They often have depression, anxiety, eating disorders, autism, learning disorders, attachment issues, separation anxiety, and psychotic illness. Many of them also come from a background with sexual abuse, trauma, intellectual disabilities, low IQ, and or parental mental illness. So there's a lot going on psychologically with these kids in addition to the gender dysphoria. As you can imagine, all of these comorbid mental health conditions and situations are strong contributors to suicidality, independently of whether the kid has gender dysphoria or not, right? So what studies have shown is that these trans-identified teens or gender-confused teens only have a slight elevated risk of suicide compared to youth with similar mental health conditions. So this puts into perspective this worry about the elevated risk of suicide for gender nonconforming or gender confused kids, is that it's not so much this gender nonconformity that is causing an elevated risk of suicide, but it's everything else that is happening alongside it. And we also know that the suicidality of gender-confused children is comparable to that of gay, lesbian, and bisexual teens. And so it is elevated compared to the general population, but it's not out of step with people with multiple mental health conditions or homosexual teens. Okay, so the treatment options. We basically have what is mainstream in the US, which is gender-affirming care, what we will discuss first, and then the alternative, which doesn't have a name, is like not gender-affirming care, sometimes it's called watchful waiting. So there are 4 stages of treatment in gender-affirming care. So the first stage is social transition. That's when the kid goes by a different name, has different pronouns, changes the way that he or she dresses. Then comes puberty blockers to halt the development of natural puberty. After that, cross-sex hormones. And the final step is the surgical removal of organs and surgical reconstruction. Right? So the proponents of gender-affirming care claim that these treatments are effective and should be commenced early. So, what does the evidence show about gender-affirming care? Well, the best available evidence suggests that there is very low certainty that gender-affirming care interventions are beneficial. Okay, why is this important to understand the level of certainty? Well, interventions are ranked from, very certain, very high certainty to very low certainty. And what we know is that when interventions have a very low certainty of bearing fruit, it leads to patients not experiencing the effects that they want from the proposed intervention. Studies show that neither hormones nor surgeries reduce the suicidality in the long term. Right? And remember that the motivation for this is that, improve the well-being of children. But the evidence that we have so far in 2023 shows that there is no improvement in the reduction of suicidality. So this narrative that says if the kid doesn't transition, he or she will commit suicide is factually inaccurate based on the current data. Okay, so the alternative treatment is the kid comes with gender dysphoria and these multiple comorbidities, is let's give the kid psychotherapy and let's see what happens, right? Let's see whether the dysphoria persists or continues, or it ends, it desists. So the US government enthusiastic and exclusive support for early gender-affirming care is out of step with the rest of the Western world. Countries in the vanguard of gender-affirming care, the UK, Sweden, and Norway are backing away from invasive interventions, whether it's puberty blockers, hormones, and surgeries. Now, this has happened in the last 12 months. Sweden no longer recommends prescribing puberty blockers and hormones to minors. In the UK, which had the famed Tavistock Gender Clinic, that clinic was closed last year, and they vowed to improve clinical standards, meaning providing actual psychotherapy support to kids that have gender issues. So it's important to understand what has happened. So these countries that were the first to do gender-affirming care, UK, Sweden, Norway, mostly UK and Scandinavian countries, that were very aggressive in favor of gender-affirming care for a couple of decades. And then in the last 2 years, they have said, we have no evidence that this works. So we are going to revert to the alternative, which is watchful waiting and psychotherapy. Let's just do nothing. Let's provide psychological support. However, it's not like we have a bunch of research showing that watchful waiting and psychotherapy work. But the worry is that, well, at least psychotherapy and watchful waiting don't involve medicating children and changing their biological makeup permanently. So, as I said, the Swedish did a U-turn on gender transitioning for kids. Now their standard of care is psychotherapy and watchful waiting. This is a couple of weeks old in Norway. They had a big investigation as to how their healthcare system was dealing with gender confused kids, and now they have decided that puberty blockers, cross-sex hormones, and surgery for kids and young people is a completely experimental treatment, and that affirmative care is not evidence-based. So they're going back to the opposite again: watchful waiting and psychotherapy. Okay, so if there is no substantial research supporting either style of treatment, right? Does it really matter? Well, let's do a comparative assessment. Affirmative care is touted as the standard of care, but it is not. It is touted as promoting well-being and reducing chances of suicide. It doesn't accomplish either, especially the latter. It is irreversible. Sometimes we hear that, well, social transition comes without any risks, but we do know that social transition increases the likelihood of medical transition and reduces the chances of natural resolution. At the Tavistock Clinic, they saw that when they put kids on their social transition first, almost 100% of them went on to puberty blockers and hormones, but remember the rate of desistance, as high as between 60 and over 80% of kids who are gender confused go on to no longer be gender confused after puberty. The other important fact is that puberty blockers are not FDA approved for the treatment of dysphoria and come with serious side effects. Puberty is not just the time when you grow hair and breasts and hips and your voice deepens. It's also those hormones affect your brain development, your bone development, your heart development. So we have seen that studies have shown that bone loss is one of the potential side effects of puberty blockers, stunted cognitive development, stunted genital development, and blindness. This discovery about blindness and puberty blockers is relatively recent, less than a year old. And when it comes to hormones, cross-sex hormones, they increase the risk of cardiovascular events, which is not something that the typical child or teenager has to worry about. Okay, so like I said, affirmative care is largely irreversible. Puberty blockers that are administered at the Tanner stage 2 of puberty, and as you can see, Tanner stage 2 in females is age 9, as early as 9, and males is as early as age 11. Is if you get puberty blockers followed by cross-sex hormones, you will be permanently infertile, sterile, and most likely unable to ever experience an orgasm. Obviously, castration, double mastectomy, hysterectomies are irreversible. And then the next step, the final step, which is the genital reconstruction, it comes with very high complication rates. So take, for example, vaginoplasties. That's when a surgeon takes a penis and it's inverted to create a neovagina. The complication rate can be up to as high as 3 and 4 surgeries. So we see, this is from a paper that talks about the complications for vaginoplasties. Between 20% to half of all operations, vaginoplasties require a second operation. We have up to 13% urinary retention. We have rectal injuries, fistulas, inadequate vaginal depth. The fistula is particularly concerning because it's the breaking of the wall between this neovagina and your rectum, right? So if you have a rectal fistula, you will have fecal matter going into this neovagina, which of course can create all kinds of issues. Now, surgically reconstructed organs are not just like normal genitals, right? And one of the things that is interesting is that the motivation for early intervention, right, is that if that kid grows up to be transgender, the idea is like, well, if we hold puberty and we do this early, right, then that kid will pass, especially if they're male. If you hold puberty, it's much easier for a male to pass for female. But one of the downsides of early intervention is that it makes the reconstruction more difficult because the raw matter, in a sense, for, say, a neovagina has to be a fully formed penis. And if there's not enough tissue to create a neovagina, that creates a bit of a problem. So take, for example, if you administer puberty blockers and then cross-sex hormones to a boy at Tanner stage 2, that kid will end up with a micropenis because they don't have enough testosterone in their body to ensure the full development of a normal penis. So where do you get the tissue to create, this neovagina? It's a colon resection. So take a part of a colon, and they use that tube of tissue to create the neovagina. And as you can imagine, the tissue of your colon has been exposed to fecal matter for many years, so it smells. And as a result, people have lower satisfaction rates, with surgeries that involve colon resections. And the other important fact is that detransition is not covered by insurance. We have seen that insurance, most insurances tend to cover transitions, but they don't cover, the reconstruction to go back to the child's normal sexed body. Now, the alternatives, watchful waiting and psychotherapy, are not invasive, right? So they have that going for them. Okay, so that is all of the facts, right? The psychological, the medical, the diagnostic issues, the prognosis, the treatments. Now, what are the moral considerations? The testimony given by detransitioners and studies on what is going on with gender affirming care suggest or confirms, I would say, something that many people intuitively believe, is that children and teenagers are probably not sufficiently developed cognitively to be able to offer informed consent, right? So their autonomy is not being promoted or respected because they are incapable of autonomously making these decisions. Informed consent in the area of medicine is absolutely necessary when substantial risks are involved, right? And the issue is not simply that they may not be sufficiently informed, although that is one of the problems that is mentioned in your readings, but the other issue is the innate cognitive and psychological underdevelopment of children and adolescents. Their brains are not fully developed. They may not be able to make sense of what they're getting into. So why is informed consent so important? Well, it's because it's what all of us deserve. We deserve to make decisions with sufficient information and with adequate understanding. It's what we deserve, so it's a matter of justice. It's also a matter of beneficence, right? The consequences are always better when we get what we want, right? And we understand what we're getting. But most importantly, if we are going to take autonomy seriously and self-determination seriously, it's important that anyone who gets into these, risky treatments knows what they're getting. And if they are incapable of consenting or they lack the information, then that is a violation of, it's not a respect for autonomy, it's a violation. So if informed consent is to be provided, what ought to be disclosed? Well, that any kind of gender affirming care is going to predispose the child to persist in their gender confusion. That most treatments are irreversible, that most pharmaceutical interventions come with significant side effects, and that we have no long-term studies supporting the benefits of treatment. And finally, that it's literally impossible to change your sex, right? We hear about sex change operation, but that is a misnomer because sex is determined by the gametes that you produce, and we cannot change that. We also have testimonies from people who have worked at many of the gender clinics in the US. This testimony here that I'm sharing with you is by Jamie Reed. She worked at the gender clinic in St. Louis at Washington University. And what she saw is that the patients were not really understanding what they were getting into. So I'm going to read you this snapshot. Hello, patients understood what they were getting into was illustrated by a call we received at the center in 2020 from a 17-year-old biological female patient who was on testosterone. She said she was bleeding from the vagina. In less than an hour, she had soaked through an extra heavy pad, her jeans, and a towel she had wrapped around her waist. The nurse at the center told her to go to the emergency room right away. We found out later this girl had intercourse, and because testosterone thins the vaginal tissues, her vaginal canal had ripped open. She had to be sedated and given surgery to repair the damage. She wasn't the only vaginal laceration case we had heard about. Okay, so the first moral consideration is like, can kids consent? Many of the writings on the topic is that they can't. And it's not something that it's that groundbreaking of an assertion, because we have all kinds of laws in place where kids cannot buy alcohol or vote or get behind the wheel or get a tattoo before the age of majority. And maybe the age of majority may not be enough, right? What we know about brain development is that it's not fully formed until the early to mid-20s. But then there's the question of like, okay, so the kids cannot consent. What should parents do, right? What is the parental responsibility here? What moral consideration should parents be mindful of? Well, Charles tells us that one of the foremost parental virtues is acceptingness, accepting your child for who he or she is. But then Davis tells us that what is a parental virtue is integrity. And remember that parental integrity is finding a balance between what the child wants and what the parent wants, right? It cannot be all about the child and it cannot be all about the parent, right? So what do these virtues demand? What does it mean to accept the child in the context of identity exploration, right? You can probably look back on your, teenage years and think about the things that you thought you were and whether these things that were so important to you remain as crucial in your life now as they were back then. What does it mean to accept the child in the context of identity exploration, but also is acceptingness embodied by gender affirming care or by the alternatives, right? Because the question is, who the child really is that the same as who the child says he or she really is, right? So that's an interesting conundrum, right? Do good parents merely accept whatever a child may want? And then we have a question of rights. It's not just a question of virtues, but it's also a question of rights. We do know that rights and trust, the right to an open future, these are the rights that the parent has to protect in childhood, so that when the child is old enough to exercise these rights, they can exercise them, when they grow to be adults. And one of the examples, remember, that David mentions that I think is particularly relevant to this discussion is the right to reproduce. A child has no right to reproduce. That would be, horrific. However, you are not allowed to sterilize children just because they have no right to reproduce when they're 12. But those are rights that the child will eventually exercise in the future. So what form of treatment protects these rights and trust, right? These rights to an open future? Is it affirmative care, or is it the alternative, the watchful waiting and psychotherapy? And what is in the best interest of the child and his or her future self? And so we have the issue of autonomy on one hand, and then we have the issues of parental virtues and rights. And then, of course, we also have the consequentialist argument, right? The consequentialist or utilitarian argument. And I think that one is easier to sort out because if, right, suicidality is not reduced, if the changes are irreversible, if there are high rates of complication, if there are many, side effects, serious side effects, then it looks like that from a consequentialist or utilitarian perspective, as Sweden, the UK, and Norway have decided, affirmative care does more harm than good. So the alternative, which is, watchful waiting and psychotherapy, may be what maximizes good consequences over bad consequences. Okay, I hope that this was useful. I know it was a little bit long, but there are so many layers to this issue that I thought it was worth the time recording this.